How are you, Robert? Nice to meet you. I'm going to be examining your knee. It's going to involve me having to look at, move, feel them. Is that okay with you? Okay, great. So I'm going to have you, if you would you just stand here for me a minute? I'm going to have you, would you just face me? There you go. Can you turn and now look at the wall? Very good. And make another turn, look at the blue wall over there, and over at the screen, if you would, and then back forward. Thank you very much. And then I'm going to have you, can you walk right down that little aisle there, and then turn around and come back at me? Okay, very good. Thank you. And you come on back. Okay, so we know we're looking for size, shape, symmetry, swelling, subluxation, scarring, all those different things, right? Very important. And scarring is very important with the knee. It's amazing how many people have had surgeries with the knee, either microsurgeries or just there's a tiny little scar where they went in, they filled it up with fluid so they could get in there and then clip stuff out. And you'd also be surprised how many people don't tell you about surgeries that they have. So you're going to definitely look for things like that on the patient. I also said we could look for things like psoriasis on our patient, right? I don't know if you've ever seen that in someone that could give you some ideas of different arthritises that they may be experiencing or will have in the future. Sometimes people, and it's more women than guys, they get these Baker cysts on the back of their knees, if you've heard of those. And you know, you can illuminate them. Did you know that? That's how you can tell if it's just a cyst or not. You just put a little flashlight on there and it goes, just lights up. You look for like evidence of subluxation, maybe like if they're like this, what might you think if the patient's knee is like this? Like a medial femur there maybe. You know, inguinal valgum may have some effect telling you something's going on with the hip. All those different things you're looking at the patient for your patient. So you're just going to go through them, right? Anything you see that's abnormal, just going to make notes. So after you do that, you're going to do what? Supine examination, right? So if you would you lay on your back close to one another. Okay, the first thing I always say you do, we're going to make a touchdown. And you want to make a touchdown right after that, right? That'll just help you to remember we're going to do temperature, dermatomes, and peripheral sensory nerves. Okay, so I'm going to be touching your knees with the back of my hand. So we're going to go like this. The back of our hand, as you know, is where it's, see, Robin has a little scar here. The back of your hand is where the skin is thinner, so you get a better feel for that. So you're going to tell. You want to definitely make sure you go over the bursas. There's main bursas. There's a supra, a pre, and an infrapatellar bursa, and of course you have your anserine bursa on that side. So make sure you hit those areas when you're doing your temperature. Okay? All right, the dermatomes, you say, I'm going to be rubbing this over your leg, just like it's going to feel like this. Okay? And when I draw it, we're going to compare side to side and tell me if there's any difference. So you can just close your eyes when we do this. And so we can just start here. We can say, okay, here's 3. Does this feel like this? And then 4, some people say they just divide the whole calf into 2 and 3, and then they do 4 down here. Some do this, they say this is 3, and then 4, they say it comes down like this. But I don't really care how you do it. So if you want to do like this, and this is 3, and this is 4, or if you want to even break 4 into 2 pieces, that's fine. And then does this feel like this? 5. Okay, so everybody got that? And the peripheral sensory nerves, so you can tell me the one that's here. The anterior what? Anterior femoral cutaneous. And which is this one over here on the outside? The lateral cutaneous nerve of the calf. Does everybody remember that? Sort of ringing bells a little bit. And what's this big S one that covers, there you go, saphenous, right? So you go through this. So you've done your temperature, your dermatomes, your peripheral sensory nerves to help you determine what's taking place with your patient. Okay. After you do that, we're going to do what? Bony palpation. So we're going to do our bony palpation. Sorry, Robin, but my hands are so cold. We're going to do here. We're going to do our femoral. Our femoral epicondyles, our tibial condyles. Don't forget to get the tibial tubercle. Back here you have the what? Tip of your head, and you have your patella. Okay. Okay. Soft tissue. We're going to go through the soft tissue. We have a lot of bursa again. We have our suprapatellar. We have our prepatellar. We have our infrapatellar, and your anserine bursa. Make sure you get those. Okay. All right. So after you've done your bursa, you might want to do your muscles, where you can come across like this, and you can say, okay, we have our quads, we can come over here, we have our IT band. Coming down on the outside, this is our anterior tibialis. Coming down on the medial side of the shin, that's your soleus there. So you get those out of the way. Then, let's see what else we have here. We have our patellar tendon. Make sure you get that. And that's was that a patellar tendon surgical procedure you had? It's right over top of it?
They cut my tendon to make my ligament.
Okay, yeah, that's what they took the center of it out. Was it for an anterior cruciate ligament?
And my MCL.
Okay, yeah, and it's held up for you, huh? Good, that's good. And of course, you have your joint lines. Your joint lines pretty much like the other swollen meniscus or one of those ligaments holding things together you may have swollen in there, right? So go through all those. Okay, after you've done your soft tissue, then we're gonna go to our seated examination. Can you sit up here on the end of here? Very good. And you can move back just a little bit on the table. What we're gonna do is put her into knee extension. We're going to do internal and external rotation. Now, when you're doing this, make sure you control your patient. So, we're going to start with our active, and I'm going to say, can you just straighten your leg for me as far as you can? Very good, thank you. Can you straighten this one? Very good. Now, what we're going to do this one, I'm going to have you turn it all the way in here and then all the way out like that, okay? Can you do that for me? Good. And then out. Good. Can you do the other one? Good. And out. Okay, now what I'm going to do is I'm going to do these motions. So we're going to bring this up, all the way up, thank you. All the way up. Always be aware, okay, if somebody's had a surgical procedure, what kind of limitations they may have. We're going to turn this one all the way out, and we're going to turn it all the way in, and all the way out, and all the way in. Okay, now what I'm going to have you do is push out against my hand. Good, thank you. Can you push out against this one? Good. Can you turn your foot in?
This way?
Yes.
Okay.
And can you turn it out? Very good. And can you turn it in? And can you turn it out? Okay, so you've gone through your active, passive, resisted range of motion. After you've done your range of motion, we're going to do a couple of things. One, we're going to measure the widest part of the calf. Okay? Remember, when you do that, I don't care which side you use, make sure that you're intelligently doing that. Then you're going to just measure, and you want to keep it, remember, the widest part of the calf, and you want to keep it parallel to the floor. Okay, she's at 13 and a half here, and I want to get 13 and a half here. I'm going to just have you push your leg back just a little bit. Thank you. That's important. Let's go over here. Okay, just a slight difference. About an eighth of an inch. Okay? Then, of course, the next thing we're going to do is what? Hit him with a hammer. Now, see, Robin's feet are on the floor, and this is the way they taught us when I was in school to do this. I don't know if they taught you guys this or not. But if I wanted to tap this, then I'm going to go like this. I'm going to just put my hand under here and rest my hand like this, and she can just let her leg be totally limp here. Find your patella. Hit the one side. And try the other one for me. It seemed like I did that exactly like that. 10 minutes later, and it seemed kind of fun. Okay, has everybody got that? Okay, so any questions about the seated exam? Okay, next we're going to have a patient lay prone, if you would. First thing you're going to do is what again? Temperature and dermatomes. So we're going to go over the patient. We're going to touch the back of their legs. Right? Yeah, I don't care if you use the same hand. Some people insist you use the same hand. I don't care if you use two different hands. Just make sure you go over it like that. Okay? Next thing we're going to do is the dermatomes. Robin, I'm going to be running this over your foot. I'm just going to feel like this. Over the back of your knee, it's going to feel like that. And you're going to tell me if one side feels like the other. Now, there's only two dermatomes I want you to think of here. Coming all the way down the medial side is what? S? 2. And coming down the lateral side is S1. So you can do this in several swipes. Most people do it in several. It seems to me like it would be okay to just do it like this. Does this feel like this? But most sources say, does this feel like this? Does this feel like this? Does this feel like this? Okay. And of course, you need to be outside is this, 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 this. Okay? So you wanna make sure you get us one of those two. Then your peripheral sensory nerves, who can tell me what this one is? It's the exact opposite of the one we found on the front. Posterior femoral cutaneous, right? And then we come down here on the lateral side, it's what? It's the small s? The sorrel, that's right. And then again, the one that covered S2 and 4 is what? Saphenous. Okay, so everybody got that? So you've done your temperature and you've done your dermatomes. Next thing, we'll do our bony palpation. Again, pretty much the same thing. Your femoral epicondyles, tibial condyle, your fibular head. Pretty much that's all you're going to run into here. You're going to have a patella to grab onto. And then your soft tissue coming here. We do have a lymph node back here, so remember that. So we want to try to feel in here for the lymph node. And it usually is the semimembranosus, membranosus, tendinosus come down, and the biceps femoris, long head, short head, as they split off, it usually sits right up in this area. Okay? So you're going to feel to see if there's any type of lymph node swelling inside there. After you've done your lymph nodes, you can go through your tendons, right? You have your semimembranosus and semitendinosus tendon on the one side. You can come down here, and of course, when you're doing the calf, be very gentle. And of course, you can just feel your hamstrings in general coming down through here and your joint lines. Did I miss anything on that? Okay, so we've done that. Next is going to be what?
Did you point the gastrocnemius bursa?
Oh, I didn't. Thank you. Gastrocnemius bursa. Where that is, ladies and gentlemen, is right here. It's just going to be sitting right on top of your femoral condyles, right here, here, and here. I don't know what happened. It took me off up there. And I'm going to put this up here as well. Here's this gastrocnemius bursa here. Does everybody see where they are? Up on top of the femoral condyles. Sorry. There we go. You have two of them, one on each side. Okay, so just come right down on top of those. So you're just going to get, okay, any tenderness in here, any irritation in there, okay? Okay, the next thing we're going to do is knee flexion. I'm going to have you, if you would please, bring your foot all the way up to your buttocks if you can. There you go, thank you. And can you bring the other one up to your buttocks? Thank you very much. And now I'm going to do that. And so I'm expecting to see what range of motion? A little what? A little more. A little more. Always ask the patient if anything causes you discomfort while we're doing these to let you know. Okay, always be slow and deliberate. Don't slam things around. And I'm going to ask you if you would please, can you push up against my hand? There you go. Thank you. And try this one. Thank you. Okay? Active, passive, resistant range of motion. Then you have orthopedic tests. And I think we practiced all the orthopedic tests in here already, didn't we? So keep them in mind. And your final consideration is what?
X-rays or not?
X-rays and that. Do I want to X-ray this patient? If I'm going to adjust her knee, I'm definitely taking an X-ray, right? I'm definitely taking an X-ray. If I suspect there's something in there, and I'm wrong, that's still a very valuable thing. You know what I mean? Sometimes not getting information is good. You know what I mean? We don't always have to get information from our examination. You can roll things in and you can roll things out. And anything that helps you in your office to help the patient, it's okay to get paid for. Remember that. I'm going to tell you what, getting money is good. Okay? You have to run your business. You have to pay your bills. You have to eat lunch once in a while, right? You don't want to sleep in your car. In fact, you got to pay for your car. So, and I can tell you, what happened to me in my office, not so much because I don't take new patients anymore, but I know it was very big in Gonstead's clinic, is people come to you for a lot of things. A lot of things. Can you fix this? I can't fix that. What about this? You know, they know that if they're not feeling well, get checked. Because for them to go to an urgent care or a physician or an emergency rooms are ridiculous. You drive past an emergency room and they charge you $300-400 just to drive past it, not even stop in. So somebody comes in and you charge them $35 to $50 for a visit, you know, they're coming to you. I just want you to know that. And if you can't help them, you can't help them. But do the things that you can for your patient, because they're going to just do that to you. That's the way they're going to relate to you, just because of simple monies. Simple monies. Okay? So if you charge them for what you're doing and you take an x-ray and you charge them, we don't charge. I had one person swear at me in my office.